Okay, today we will try to complete up the stomach, duodenum, small bowel, and the large bowel conditions. Okay, they seem to be pretty easy, not too difficult, but let's try to complete as much as we can. All right, okay. You have to understand one thing. Okay, I think maybe for the guys who has forgot what we have been dealing about, yes, we have been dealing about the fluoroscopic examinations, different types of fluoroscopic examinations of the gastrointestinal tract, and we have completed a content that is related down to the esophagus. So we are going down to stomach and duodenum today. All right. So the lumen of the stomach generally most of the times is studied by upper endoscopy, just because we have to through endoscopy we will be getting down a real-time visualization of the gastric mucosa. But actually this one, when you are trying to do the GI endoscopy, you call it as upper GI endoscopy, okay, or gastroscopy also. Okay, when you try to do it, actually you are looking down only into the surface or the structures that are present only inside the stomach. Actually, what is present inside the stomach, it's only the mucosal layers on the muscularis that is present down inside the stomach. You are going to go until the pyloric sphincter, and then you are going to enter down into the duodenum and jejunum. But you are still staying down within the same loop. You are not going to outside. You are not going to see the relation between the stomach and the liver. You are not going to see the blood vessel relationship through the endoscope itself. So you are just going to look down only into the gastric area, okay, only inside of the stomach, but not outside of the stomach. So if you are going to look at the outside of the stomach and its anatomical relations, obviously endoscopy is not a preferable study. So to study the wall thickness and the structures outside of the stomach are generally done by a CD examination of the abdomen with an oral contrast. So barium sulfate oral contrast will be taken down, and then you are not going to perform a fluoroscopic examination, but you are technically trying to find out the CD examination and do it so that you can actually understand the relations of the structures outside of the stomach, and then also know about the wall thickness. So biphasic upper gastrointestinal examinations, okay, upper GI, which include the study of the esophagus, stomach, duodenum, actually are much more sensitive and cost effective, easy, and reliability is high, and also one of the most non-invasive alternatives. You have to understand, by any kind of an endoscopic study, endoscopy is a metallic camera tube which is actually inserted into the stomach during from the oropharynx. Since it is a metallic flexible tube, the thing what actually happens is that it possesses a risk of perforation from the entry point till exit point. Perforation can happen at any level. So the most important complication that is related down to endoscopy is it is completely uncomfortable. Okay, it needs a lot of preparation before. For example, to say you need to anesthetize the patient, prevent the gag reflexes, and you need a experienced physician or a licensed endoscopic physician or a surgeon or a technician to do this one. But when compared to them, actually this biphasic upper gastrointestinal tract examination technically do not possess any kind of risks except for radiation risk. Okay, radiation risk also, it is in a controlled environment, even the radiation risk is completely negligible these days. So it is cost effective, it is as sensitive, it is and the best non-invasive alternative. Okay, whereas endoscopy is completely invasive technique. It is has got 100% sensitivity and specificity in detecting the pathology of the stomach and the duodenum, but still it has got a higher risk. Generally speaking, upper GI endoscopy is used for both diagnostic and therapeutic purposes. Okay, we will study how it is going to be both diagnostic and therapeutic. But CT examination or barium study or fluoroscopy is technically not completely therapeutic. It is mostly diagnostic. Okay, diagnostic accuracy is much more higher, but the benefit of an upper GI endoscopy, it is both diagnostic and therapeutic, right? And the first thing that we are going to learn is a very peculiar disease, okay, which is known as the gastric ulcer disease, okay, which is also called as the peptic ulcer disease, which is a quite common kind of condition. Okay, gastric ulcers are the quite common kind of conditions which happens and which has got an association with a bacteria which is a helicobacter bacteria, and for which is responsible for most of the cases having gastric ulcer disease. Okay, uh, gastric ulcers are caused by excessive secretion of the gastric acid, which are reactivated by the Helicobacteria pylori, and they are the ones that are actually causing this ulcerations. So it is more of an, rather than an inflammatory condition, it is actually more of a necrotic condition, which the bacteria is responsible for producing the ulcers. Okay, erosions inside the gastric mucosa is actually caused by the bacteria, right? And also, one of the most important potent risk factors for developing down gastric ulcers is non-steroidal anti-inflammatory agents, also which is responsible for producing gastric intestinal ulcers. I think last time I have asked one of the student to find out the mechanism of action that is related down to the non-steroidal anti-inflammatory agents like diclofenac, acetaminophen, aceclofenac, and aspirin to cause why would they cause gastric ulcers? So did you guys find out? Can somebody tell me why does have these non-steroidal anti-inflammatory drugs needs to cause gastric ulcers? Somebody? Don't remember all, but it is related to COX-1 or COX-2. Okay? Then why don't you try to find it once again and tell me why it is causing again? All students, okay? Maybe try to do it. Actually, you see here, all the NSAIDs are the activations. Okay, you see here any kind of inflammation. What is NSAIDs actually used for? Aceclofenac, paracetamol. Okay, so they are going to block COX-1 and inhibit prostaglandin formation, right? They are analgesics, right? Yes. Okay. So what are prostaglandins responsible for? When you actually reduce prostaglandins, what happens? NSAIDs actually, production hormone prostaglandins, right? So when they actually producing prostaglandins, what happens is that there is increased mucus secretion, and as a result, there will be increased HCl secretion, and as a result of increased HCl secretion, there will be more acid production, and finally it causes a gastric ulcer. All right. Yes. Yes, because of prostaglandins, right? Because of the involvement of the prostaglandins. So that's the reason. NSAIDs has got a direct relation down to, reduction of the gastric ulcers. Okay, but however, the people that still wanted to know the complete detailed mechanism, I suggest you better go down and find out what is the reason behind the NSAIDs and some of the drugs causing gastric ulcers. Okay, right. Uh, so one of the most important thing you have to never ever forget is this Helicobacter pylori actually accounts for formation of the gastric ulcer disease, and as well as the non-steroidal anti-inflammatory agents also causing the gastric ulcers. And you have to remember another more important clinical factor here, that most of the ulcers are usually formed on the lesser curvature or the posterior wall or the region of the body of the antrum. Okay. uh, Actually it is formed down more on the lesser curvature, which is present onto the right side, okay, or to the medial side, because that is the first area where actually it has got the esophageal, the filling up of the stomach is actually going to happen through lesser curvature. Okay. And then posterior wall of the antrum are the something which is necessary here, because the first peristaltic movement is actually going to cause down from the posterior wall of the region. And wherever the gastric acid is being secreted, the food goes down and the gastric acid comes above, right? So that's the reason they are going to stay along the level of the posterior wall and the lesser curvature, where there will be high contents or the high influence of the gastric acid here at this level. So that's the reason the gastric ulcers mostly happened along the level of the lesser curvature. Remember, any kind of a gastric ulcer, a smaller erosion or a bigger erosion, or a benign condition or a malignant condition, most of the times is tend to be happening along the lesser curvature, or secondly, or the posterior wall in the region of the body or the antrum. But you have to understand here, gastric ulcer is an generally, an inflammatory condition. Okay, it is actually happening because of the hyperacidity. Okay, and they are going to cause, ulcerations, erosion of the gastric mucosa, which will eventually take time to heal by fibrosis, and generally they will tend to become benign. But so 95% of the ulcers that are actually caused by the Helicobacter pylori are generally, benign. But there are some other also conditions like alcoholism, and also over exposure or overproduction of the gastric acid secretion will eventually cause 5% of these lesions to become gastric malignancies. Okay, so gastric ulcer is benign, whereas gastric carcinoma is being malignant. But you have to understand one thing, that the precursor that is responsible for gastric carcinoma is actually gastric ulcer. One of the risk factors for development of gastric carcinoma is nothing but your gastric ulcer. But still, 5% is not a less amount. There are so many people, and which is also one of the poor prognostic diseases. Gastric ulcers, gastric cancer also has got one of the poor prognostic conditions. So you cannot ignore any kind of a condition that is related down to abdominal complaint, especially if the patient has been suffering from gastric ulcer history. All right. So first, we are going to look down at the benign ulcer that is present down along the lesser curvature of the gastric uh, cavity. See, this is actually a profile view. Okay, last time we have been looking at what is a profile view and an en-face view, right? Okay, so can somebody tell me what is a profile view? Okay, okay. Profile view is you are trying to look down, seeing from above. So where exactly are you looking? Okay, yes, seeing from above, but are you looking from sideways, or are you looking from just directly above perpendicularly? See, you are standing directly away from it, and then you are trying to look at it. Okay, doesn't matter perpendicularly, or but you are just looking it rather than in a different angle. Okay, you are looking directly at the lesion. Okay, you are directly looking at the lesion. So here what we can actually see is that, okay, this is an inverted image. Okay, this is the real-time fluoroscopic image, so that's the reason you are not seeing the, you know, the fluoroscopic content or the contrast material as the black thing here. Okay, I think if you can remember the, you know, what do you say, the first X-ray that is taken by Konrad Röntgen also tried to appear like this, right? Where the bones appeared black and the background appeared white. Do you remember that picture? Okay, so fluoroscopy is also actually showing up like this. Okay, you see here the background is completely white, which in the other way, when you are actually trying to develop or the post make process this film, actually what happens is that you are going to look at the same image which has got a black background, something. Okay, for example, yeah, something like this. You are going to have a black background, and then you are going to see the contrast material as white. But see here, what we are actually trying to look at is it in a different way, but still it is making all the same sense. Okay, here the black content is about the, you know, the mucosa collection of the contrast material. Okay, so you are looking at a area, a specific area where there is a specific collection along, you know, the erosed area of the gastric mucosa, where there is an erosion here and there is a trough that has been caused, and there is a collection of the barium inside this one. So actually what should have happened is that, okay, if it is normal, it should actually look like the gastric rugae has been completely even, and you see here there should be no such kind of lesion or a collection of the barium along this area. So it should be looking quite smooth, and yeah, the gastric whatever the contrast material that has been given down has to flow down freely, but there won't be any collections. But you don't see such kind of a picture here, and you see here there is an ulcer crater. Okay, remember, this is an ulcer crater which is actually forming an ulcer crater which is actually forming depression, and the depression is collecting down the gastric contrast material, and that contrast material is actually going to form a circular ring-like structure which actually shows up as an ulcer collar. Okay, so this one you have to remember, ulcer collar is one of the most important, okay, one of the most important characteristic feature related down to a gastric ulcer. Remember, the ulcer collection was present on multiple views. It should not only be present down in the profile view, but should also be able to present down in the invasive view as well. Okay, so which is an important characteristic for an ulcer, which is called as persistence. Okay, and then there is an amount of you know, there is an amount of edematous tissue that surrounds the ulcer, which is actually the white dotted one. Okay, this is actually called as the ulcer collar. You have to remember, first, there is a collection of barium along the lesser curvature. Okay, if there is a correct collection of the barium along the lesser curvature, is actually the one that is actually going to show that it is representing the gastric ulcer. And the second thing that we are going to look along is the ulcer persistence. Okay, ulcer collection on multiple views, so which means to say persistence should be there. Persistence in the sense it should be present in multiple views, in multiple angles, right? And then finally, there should be an edematous tissue that is surrounding the ulcer, which is actually called as ulcer collar. All right. So three radiographic features are most important in diagnosis of a benign gastric ulcer. Technically, it is a very easy diagnosis. Okay, very simple one. The first thing what we know is that okay, it should collect gastric ulcer is an mucosa erosion. Mucosa erosion actually causes depression in the gastric mucosa. Depression in the gastric mucosa are liable to collect down the barium contrast material. When the barium contrast material collects out, it actually forms out an area, okay, which is actually called as a niche. Okay, remember, it actually collects an area called as niche. Okay, and when the niche is formed, okay, niche is nothing but an area, a specific area that is looking prominent. Okay, has to look white. Niche is a collection of the barium along the ulcerous region. Okay, wherever there is an ulcer, there is a depression, and the depression collects barium, and the collection of the barium actually it looks specifically much more white. So it is actually called as a niche. Okay, so that niche will be there. Okay, first thing, and actually which has got it is present. That niche is present all over. It is present down in multiple views. Okay, and there is an edematous tissue that is surrounding, okay, which edematous tissue actually suggests that there has been healing has been activated. Okay, and then which one actually forms down a ring-like structure, which is actually called as the ulcer collar. Okay, so three types of radiographic features are important in diagnosing a benign lesser curvature gastric ulcer, right? You can see here, this is also one showing up a classical niche here. And here in an invasive view, here, what we actually see is that whenever there is an ulcer, you actually have to see that there is another specific radiographic sign. Uh, if you can remember, okay, let me show up. If you can remember the process of wound healing, okay, I think maybe it is hard to imagine for you guys, but let me show you how actually it looks. Can everybody see the blackboard? Yes. Okay. You see here. Let us say this is the skin surface. Okay, and there is some kind of an erosion of the tissue here. Yes. So what actually happens is that it heals over time, right? Any kind of a skin tissue will heal over time. This is when I'm looking from the side. Actually, that is how the depression or the erosion of the mucosa happened. Let me try to look at it from above. Okay, and let us say there is some kind of a depression, which is actually from above. It is looking like this. So, and there is an edema collection around the area, right? It not only matter on the skin, it can happen in any mucosal layer, okay? So try to understand it that way. When there is something like this, so this is the collar, okay, which is the edematous collar. You are like trying to look at around the place, okay? This is an ulcer collar, and this is the ulcer trough, which is actually collecting some kind of a material inside it. Then now let us imagine if this one is trying to heal out, what actually happens? This one is actually forming a thick fibrosed wall, right? Okay, thick fibrosed wall. I think if you can remember the mechanism of fibrosis down in the lungs, what actually happens? It is actually causing atelectasis also, right? It is actually pulling on the structures that are present surrounding in that place. Okay, because mucosa is a connective tissue, so what actually happens is that it is pulling up all the structures that are present near it, right? The fibrosis is the one that is actually causing the traction bronchiectasis, right? I think you remember that in the process of tuberculosis when we are trying to learn about it. And the same thing actually is also happening here. It is also pulling down the surrounding connective tissue structures, which will actually happen like this. For example, to say whenever you have a wound, okay, whenever you have a wound, what actually happens, I think you can see this skin that is being close to the area that has been actually forming this black crust. Okay, whenever, let us say, if you have a wound, if you have a black crust around it, you can, if you can take a magnifying glass or you try to look with the naked eye very closely along the wound, you can actually see that the mucosa, the skin mucosa, is actually something like this, right? Yes or no? Did you observe this anytime? If anybody has have wounds, smaller wounds, bigger wounds, yes, right? I think you know what exactly I'm talking about. When you actually look closer, what actually happens is that there is this kind of skin folds that are actually coming around that area wherever you have wound. Yes or no? And then it is actually, that is the one actually how attraction bronchiectasis is happening as well, right? But that is different. But here, what actually you can see is that you can see the whole mucosa surrounding the ulcer actually being pulled. Okay, there will be in the invasive view. Okay, when you are trying to look it uh, completely along the view where it is showing up the whole abdomen. Okay, in the invasive view, you are going to look at the lesion completely in from a side angle. Okay, along the lesser curvature, you are trying to look at the lesser curvature from a side view, cross-sectional view, and then, for example, to say you are looking sagittally. Okay, right? And what actually happens, you can see here, there are these folds of the gastric mucosa completely coming and redirecting towards the central area. Yes or no? So the ulcer margin and the gastric rugal folds are coming down and collecting down to this place. See, from every side of the stomach, what actually happens, these gastric rugae are coming and getting closed along to the central correction. So such one is actually a representation of a benign gastric ulcer. You understand? What actually are these folds? Okay, what are these actually folds? These are the gastric folds. These are the gastric mucosal folds, which are redirected down towards the center, by which the same mechanism what we have seen on the skin. Okay, there is no bigger difference between that mucosa and this mucosa, except for the layerings. This one has got the mucosa and the serosa layers, but skin has got some other extra, something around like 10 to 12 layers. Okay, skin has got 10 to 12 layers, but this one does not have that many layers. Okay, skin is a complicated tissue, but this one is not technically skin, so they are more liable to get eroded very easily. You have to understand that one thing, that in the invasive view, numerous gastric folds are going to radiate to the ulcer margin, okay, are going to radiate to the ulcer margin and has a central collection. So representing the ulcer itself. So this one is actually meant to say that this kind of an ulcer is actually a healing ulcer, but still healing ulcer in the sense it is actually going to show you that it is benign in nature, as simple. So benign gastric ulcers, okay, for example, to say the wound what we have seen down on the skin also, not every wound is going to cause a complete observable or influential scar, right? For example, to say uh, let us say I have got an accident along the on my knee, and I have just erased a little area of my you know superior surface of the skin. it is unlikely to produce me a very, very thickened fibrous scar like a keloid, right? It is unlikely to cause. But let us say I have gone a surgical incision and it was quite deep, and also it was present down on the abdomen, okay? And it is likely to cause a keloid, or it is more likely to cause some kind of a hypertrophic scar, right? So that is also the same thing happening here. A little erosion would certainly try to heal up and will be actually forming with the less fibrosis and less uh, uh, sorry complete healing is possible along the mucosa, and it is more liable to cause a benign gastric ulcer. But chronic gastric ulcers are liable to cause gastric carcinoma. Okay, now you have to understand one thing. Yes, for the last few years there has been a complete decline of the gastric carcinoma in the United States. Well, since we are not actually dealing about the United States here, since we are dealing about Asian countries, you still see here in Asian countries, yes, gastric carcinoma, particularly in China, yes, gastric cancer remains, one of the most important diseases that are actually causing death, right? Gastric carcinoma, one of the most important risk factor is excessive secretion of gastric acid and recurrent gastric ulcers, NSAID abuses, and then you are going to alcoholism, and smoking is considered to be one of the most important reasons for causing gastric cancers, right? And however, it still remain high even down in the developed countries, because most of the times people are not frequently diagnosed until or after they have completely developed a gastric cancer lesion. Okay, so most of the people wouldn't evidently know that they have gastric cancer, or most also don't know that they have been suffering from gastritis or gastric ulcer disease. This one actually happens because most of the times people do perceive the abdominal pain, the upper gastric pain, mid epigastric pain as a sign of hunger. Okay, but they won't be taking down it very seriously as if as hypersecretion of the gastric acid. I think if we can remember uh, the gastric motility, right? If you can remember the function of the VMT last time, okay, uh, which one is actually causing down the motility of the intestines, or the complete peristaltic movement of the intestine every 90 minutes, right? So such kind of peristaltic movements will be activating down the secretion of the gastric acid, which eventually is actually a sign that either you are hungry or either the process of digestion is going to happen, because the people are going to follow biological rhythms. Okay, so it is going to happen down as a biological clock, as set by the biological clock, and you will be releasing enzymes and hormones accordingly in a timely manner. But in a sedentary lifestyle or in other conditions, what actually happens is that this biological rhythms will be disrupted. One, okay, there will be a lot of gastric acid secretions, improper digestion, and gastric acid secretion without the production, sorry, without the presence of the food. All other conditions are actually going to cause increased erosion, increased stress upon the gastric mucosa. So that's the reason they are going to form the gastric ulcers. So people who ever actually are under a risk of gastric ulcer secretion, now everybody is at a risk of developing gastric ulcer, but very few people are going to get down into complete progressive state. The only reason because is that it has got a sensitivity towards the development of the H. pylori. Okay, some of the people are going having a very hypersensitivity towards H. pylori. So what actually happens is that the people who has got urease enzyme, Okay, urease enzyme, what actually happens is that production of, actually what is the function of urease is that it is going to protect you from acidic environment. But in this H pylori, what actually is that they absorb of the urease, and finally, they don't eventually protect you from the gastric environment. So that is how H pylori is actually causing the gastric ulcers. So this one will be activated more and more and more in gastric ulcer patients, and what happens is that they are going to eventually end up down into gastric carcinoma. And that's the reason you are actually calling this condition as gastric adenocarcinoma. And it actually occurs in the distal third of the stomach along the lesser curvature. Okay, they are more likely to occur along the distal third of the lesser curvature. Okay, gastric carcinomas, remember it, precursor is gastric ulcer. Okay, and when we are trying to diagnose a gastric ulcer, yes, we are going to perform a double contrast upper gastrointestinal fluoroscopic examination along with the CT scan of the abdomen, which can completely demonstrate a gastric carcinoma. Last time, I think I have told you what exactly these gastric carcinomas give you. It actually gives you a filling defect, right? And then CT is utilized actually for the staging of the extent of the tumor, okay, extension of the tumor. First thing, TNM classification will be done, and then degree of the spread. Okay, metastatic changes, tumors, nodules, all the things, and local invasion and distant metastasis is all the thing that is actually done upon a CT. And then double contrast is actually going to demonstrate that the complete presence of the or complete vegetative state of the gastric cancer. So in this relation, actually what we try to do is that either we go with double contrast along with CT scan, or you do the double contrast study as an individual thing and CT scan as an individual thing, and finally try to correlate both the radiographic features together and confirm the diagnosis. Okay. Uh, Gastric carcinomas, actually, there are so many types of them. Okay, let us try to understand few types. Actually, gastric carcinomas may be polypoid. First, and try to understand the term here. Polypoid is, generally speaking, there will be multiple polyps. Okay, rather than developing as a single, a single mass, they will be developing multiple masses, and then all of those masses will be joining together down to form a single mass later on in the later stages. So polypoid, it will be having multiple poids because the villus are going to form this one. And then it is as infiltrating. Infiltrating means to say it is actually going to happen from the serosa and mucosal layers, which is actually called as also a condition called as linitis plastica. Okay, it is going to cause a condition that is called as linitis plastica. Try to understand the term here, linitis plastica, in the sense is that plastica is something like fibrosed or healing, okay, or pulling, okay, and linitis is it actually infiltrating. So any kind of an lesion that has been erosing out and also pulling and infiltrating into the surrounding regions is actually called as a linitis plastica. They are more likely to get fibrosed and they are more likely to get eroded over time. And then uh, they are going to progress down into ulcerative forms. Okay, polypoid, infiltrating, and then ulcerative forms. So this is actually the progression or the types of the gastric carcinoma, right? And then you have to understand here one thing, even though gastric carcinoma can be prevented, even though gastric carcinoma can be controlled well, but still, you have to understand that the mortality that is related down to gastric cancer is quite high, which is the poor prognosis. And you have to understand one big important factor of death in these people is that they do not even know that they have developed cancer. And they must be thinking that yes, this pain is only just related to gastric cancer. Sorry, the pain is going to relate down into gastric ulcer, meaning epigastric pain. Okay, whenever that is with the presence of food or generally the food relieves the pain. Okay, depending upon. Generally, if there is a food presence inside the stomach, yes, it actually, you know, there will be pain, and then there will be severe bleeding that might be related down to this erosion. Because last time I said that the lesser curvature of the stomach is supplied by the left gastric artery, so there will be bleeding. There will be higher chances of bleeding. So that is the reason, for one of the reasons for melena in these kinds of patients. Okay, and then it might be happening. It might be eventually causing perforations, or it might be causing obstructions. So the whole progression doesn't matter, whatever the type of things you know uh, produces uh, a ulcer. It is, they are not going to even perceive it as that they are developing down the gastric cancer. So what actually happens is that there will be production of increased gastrin, which are activated the parietal cells, and again the parietal cells activate the HCl, and HCl is the one that is actually going to cause this erosion. So we call this kind of a condition as Zollinger, okay, Ellison, Ellison syndrome. Okay, have you heard this term before? Right, I think last time also I gave you certain names for you to remember and find out, right? Like Mallory-Weiss tear, Boyer-Harris syndrome, Nutcracker esophagus, others. So did you guys find it out? Yes, no? Last time I gave you certain like 5 or 6 terms to find out and try to understand those conditions, right? Did you guys find out? Yes or no, guys? Can everybody hear me? No? Okay, that's fine. So try to find it once again. Try to find it out. Okay. All right. So here it is going to cause, well, so Zollinger-Ellison syndrome also. No, see, Zollinger-Ellison syndrome is nothing but, okay, it is actually, a gastrinoma, okay. What actually the situation is, there will be increased secretion of the gastrin, okay, which is activated by the non-beta cell tumors, okay, of the pancreas, which actually causes increased production of gastrin, which finally activates the parietal cells, and the parietal cells are the one that actually releases the hydrochloric acid, right, acid, and then they eventually are going to form ulcers. So that's the thing. It is actually called as Zollinger-Ellison syndrome. All right. Yes, Sandra, is this clear? Right. Okay. So you have to understand that is that also one of the risk factors. And then you see here, like I said, that they are happening in the distal 1/3 of the stomach along the lesser curvature. And then double contrast and CT scans of the abdomen can demonstrate gastric cancers. Okay, simple. That is also understood very easily. And then utilized for the staging and degree of the spread. That is also understood. There are three types: polypoid, infiltrating, and ulcerating. Yes, that is also fine. But you have to understand, last time where I told you what exactly is a filling defect, right? Whenever there is an elevation along the mucosa, it is technically going to cause the disperse of the barium content without collecting around, along with it, right? So there is a mass, and there is going to be a dispersion of along the dispersion of the this barium content. So what actually happens is that it is going to cause a simple area of hypolucency. Okay, This is going to cause a formation of a black area, which is actually called as a filling defect. Okay, so now you have to understand this is the lesser curvature of the stomach and this is the greater curvature. And along the distal one-third part of the lesser curvature, you can actually see that there is a polypoid, okay, differential, see, in an irregular shape, which actually there are inward projections, and you are going to see that there is a displacement, okay, dispersion or the displacement of the barium, which is actually forming a radiolucent area, irregular radiolucent area, which is actually representing a polypoid filling defect. Okay, so that one is actually suggesting you that you might be looking down at a carcinoma. And then you have to see contained within a mass seen in the emphyse is an irregularly shaped of collection that barium that represents as ulceration. So you can see here there is also one area of a niche along the hyperlucent area. So a niche along within a filling defect, okay, a niche that is present within a filling defect is the one that is actually looking that you are looking at ulcerative form of gastric carcinoma. Did you understand? Okay. So ulcerative form of gastric carcinoma, you are nothing but you are looking at an adenocarcinoma of the stomach. Did you understand this point? Is this clear? Right? That is what we are talking about, right, Benedict? You see? Benedict, that is what we are talking about, I guess, right? Give the full diagnosis of gastric carcinoma with the imaging. Yes, with the imaging, what you are going to find out first, you have to suspect up if the patient has got a relation down to the gastric ulcers or not. Okay, first you have got a complete risk factors like uh, complete risk factors that is related down to the gastric ulcers, increased productions, alcoholism, Zollinger-Ellison syndrome also has got a sensitivity towards Helicobacter pylori. So you have found it. Then you are going to do up the what do you say, which is related down to the fluoroscopic examination. Then on the fluoroscopic examination, you are going to see along the distal one third of the stomach, okay, lesser curvature of the stomach, what you're going to see is that you're going to see a polypoid filling defect area because it has been displacing the barium, which suggests that you might be looking down at a mass. And also some areas might also be presenting down as the hyperlucent areas with a hyper density that is present in between, which actually suggesting a collection of a barium. Okay, so a niche seen within a filling defect is a characteristic feature of ulcerative form of gastric cancer, which is the adenocarcinoma. Right? Biopsy, generally, here you are going to confirm, do the biopsy to confirm the activity of urease, that is by the H. pylori infection. Okay, on the biopsy you are going to look at the Helicobacter pylori being active. Okay, and you are going to see the urease activity. So that is what biopsy is used for. Yes, Benedict, is this fine? Right? And then also there are some other screening tests like ELISA, or also something which is related down to urease breath test. Okay, but these one are actually done for screening purposes and eradication purposes. Okay, because Helicobacter pylori seems to be one of the most important risk factor for development of gastric ulcers as well as gastric cancer. So what actually you need to do is that you need to go and eradicate. Okay, you need to eradicate H. pylori. So but there are also other studies. And then also if there is any people with suspected Zollinger-Ellison syndrome, what you are actually also going to do is that you are going to uh, also monitor the secretin and the gastrin levels. Okay, because since there is an increase in gastrin levels within the uh, stomach. So that's the reason, which eventually is the one that is actually causing the gastric ulcers. So which also seems to be one of the most important reason. But doesn't matter which etiological factor it is. These radiological signs that you are looking at is actually dependent upon the dispersion of the barium and the type of erosion and type of collection or type of dispersion. Simple, right? I think you understood what exactly the radiographic changes actually does not completely give you which is the etiological origin, but will certainly give you an information that is related down to the typing. Okay, right. And then you see here, there is another thing also you are trying to look at here. The white arrows are the one that are actually forming the walls to become much more concave. Okay, the walls to become much more concave and rigid, and which is the one that is actually showing up a sign of malignancy. Okay, let us say a fibrous tissue is rigid, it is immobile, and right, and then the stomach would actually display one of the things that is actually showing up that it is not actually moving. There is a lack of distensibility and lack of normal motility. So, which means to say loss of complete peristaltic movement. So, such kind of a thing is actually a typical application of a lentis plastica. Okay, lentis plastica is a condition actually. The thing is that plastic, it became plastic. Okay, plastic in the sense it is completely becoming the lack of distensibility and lack of movement. So there is no peristalsis of the stomach, and it is acquiring a shape. Okay, and the stomach that is being acquiring a shape as completely rigid thing. So that's the reason we are calling it as plastica. It is becoming rigid, and it is actually showing up a lot of concave inward walls. Okay, so that one is actually suggesting you that you might be looking at infiltrating adenocarcinoma of the stomach. So you see here, this one is ulcerative type, where there is a niche among the filling defect, along with the polypoid filling defects along the distal one third of the lesser curvature. And here also along the complete lesser curvature or the greater curvature of the abdomen, along the lesser curvature, what are you going to try to do is that a certain area of the stomach is actually going to be, sorry, the entire body of the stomach is actually going to do uh, a complete lack of distension, and there will be absent movements. Okay, peristaltic movement is not going to happen only in the stomach. Okay, this is not ileus. Okay, this is not paralytic ileus. Don't confuse with paralytic ileus to this one. Paralytic ileus is related to now to the intestine. This we are talking only about the stomach. Okay, so there is a difference. Limitis plastica is only present in the stomach, but a paralytic ileus, which is entirely different, okay, which is happening only in the intestine. All right, and then which one is actually also showing up concave inward gastric walls. So that one is the one that is suggesting you that you are looking at a condition as infiltrating adenocarcinoma of the stomach. So this kind of typical appearance is actually called as linitis plastica. Okay, remember this is a very important definition to understand. Okay, and then there are other mass lesions that may resemble gastric carcinomas, generally like leiomyomas, which are actually, being arising from the muscularis layers, and then the wall lesion that is characteristically that ulcerates. Okay, and then lymphomas. Okay, gastric wall. Okay, gastric wall, a benign gastric wall lesion. Okay, leiomyomas. It can be happening from the muscularis layer of the stomach, and then lymphomas, which is actually produce diffusely thickening folds or multiple masses inside the stomach. Okay, so these are actually, there is also another condition which is called as, okay, I think maybe you have heard about this name. Okay, have you heard about this name called as malt? Yes or no? Can somebody tell me what is a malt? What is malt? Full form? Somebody tell me what is malt. Okay, it is actually called as, yes, mucosa associated lymphoid tissue is malt. Okay, and a cancer that is happening within this malt, within this tissue, is actually called as maltoma. Okay, it is called as maltoma. Okay, right? So this is the one that is actually a type of B cell non-Hodgkin's lymphoma. That is the one that is actually causing down as a cancer here. So it is actually called, complete form is mucosa associated. Okay, mucosa associated lymphoid. Okay, lymphoid uh, tissue carcinoma. Okay, is actually called as a maltoma. So that one is also one of the types which is related down to gastric cancers. All right, and also which actually diffusely thickened folds and causes multiple masses inside the stomach. All right, and then we're going to look at another suspected conditions is that you're going to look at the duodenal ulcer. You have to understand even the duodenal ulcer has got this same kind of reason like gastric ulcer itself. They are also going to be caused by the H. pylori infection. But what is the difference between a gastric ulcer and a duodenal ulcer when they are? One is happening inside the stomach and one is happening inside the duodenum. But you also have to understand one that there is a clinical difference that is presented in between the gastric ulcer and the duodenal ulcer. Okay, the gastric ulcer is the one that is actually causing pain upon taking food, but the duodenal ulcer is the one that actually relieves the pain. Okay, food presence actually relieves the pain. So yeah, did you learn this one in diagnostics? Okay, if you did not learn it, maybe sometime after a few days when you are trying to learn about the gastrointestinal system, you have to understand the difference between the diagnosis of a gastric ulcer and a duodenal ulcer. Even in the pharmacological sessions, you are going to learn about the difference between a gastric ulcer and a duodenal ulcer clinically. So if you did not learn it there, better learn it now. Okay, so the thing is that gastric ulcer is going to be causing presence of food causes pain. But in a duodenal ulcer, you are going the food presence of food actually relieves the pain. And then both of them are caused by the H. pylori. One is caused along the lesser curvature of the stomach, other is actually happening along the first part of the duodenum. Actually, you see here it occurs down in the duodenal bulb, and then majority are going to happen along the anterior wall of the bulb. And then you are going to see here actually again the same thing, double contrast study. A along with the barium study is the one that has got the 90% sensitivity in detecting duodenal ulcers. And you have to see here, you are also going to look at the same kind of thing here as well. But you are going to look at down in the duodenal area, but rather than looking at the abdominal area. How can you actually recognize that the duodenum and the stomach? How are you going to recognize it? Okay, you are going to recognize it by the sudden narrowing of the stomach, which is actually the location of the pyloric sphincter, right? The opening of the stomach is nothing but your pyloric sphincter, right? So along that one is actually a sudden sudden narrowing down of the gastric area is actually the region for pyloric sphincter. And then the next part that is starting down from here is actually the duodenum. Okay, and then you are going to see the same thing. You are going to see an area of nishi as well. Okay, you are just going to see the nishi itself, right? You see here there is a white hyperdense oval round collection of barium along the duodenum, right? So this one is a nishi. And then when you are going to look along the other regions, there is a surrounding zone of edema. Okay, surrounding zone of edema. So that is actually displacing the barium around the ulcer. Okay, around the ulcer there is a displacement of edema. So that one is actually the duodenal ulcer. Since you are looking at it in the region of duodenum, so that's the reason you are calling it as duodenal ulcer. So you have to remember which level, how and what level, how that level looks like. Stomach has to something look like this. Okay. Okay, whenever you are trying to look at the stomach, you are going to look at in the en-face view or the profile view. It actually has to look like this. Okay, and duodenum is the one that is actually looking like this. So there is a difference between the stomach and the duodenum area. Okay, but it is not something like that the lesion is going to tell you which area are you looking at. No, it doesn't happen. Even if it is in the stomach, the ulcer, or even if it is present down in the duodenum, yes, they are going to appear down as white barium collected areas, which is actually called as a lesion, right? But you are going to represent by the anatomy. Okay, so you are going to recognize it by the anatomical location, and then you are going to make out a decision if it is a duodenal ulcer or a gastric ulcer in case of radiology. Okay, and then this is again a characteristic feature and of duodenal ulcer, but when these ulcers heal, they are likely to do so with scarring. Generally, they form scars and deforms the normal triangular contour of the bulb. Okay, so the duodenal bulb actually is the triangular contour should be present down here, but the duodenal bulb will eventually lose its contour. So loss of contour of the duodenal bulb is the one that is actually saying that you are might be looking at the case of acute duodenal ulcer. And you have to understand one thing: everything that erodes actually for ulcerates, and everything that ulcerates eventually has to heal, and these healing eventually will cause complications, okay, which are generally on CT demonstrated, and they will be obstruction, the same thing that might be happening down, which is down in the stomach, where there will be a cancer and it is actually causing the complete obstruction of the stomach. Okay, so the same thing is going to happen here. Yes, it is going to cause the obstruction, right? And then it is eventually likely to perforate, okay, into the peritoneal cavity, which is the most important reason for peritonitis. Okay, if there is perforation, you are going to call it as a hollow viscous. Okay, remember this term, hollow. Okay, viscous. Remember, perforated ulcer is actually called as a hollow viscous. Perforation of a hollow viscous. Hollow viscous, which is nothing but any hollow tube. Okay, either stomach, intestines, or what do you say, duodenum, jejunum. Any part of the gastrointestinal tract is called as a hollow viscous. And if there is a perforation, you will be having two conditions, which is called as a sorry, release of, okay, release of gastric or intestinal contents, okay, intestinal contents into a retroperitoneum. Okay, retroperitoneum. And then you also are going to see which is actually causing peritonitis, okay, which is causing peritonitis. And if it is actually happening because of the perforation, then you are also going to see another condition that is also called as pneumoperitoneum. Okay, remember, there is other condition where there will be escape of air into the abdominal cavity. Okay, generally the air, all the air that is present down in the abdominal cavity is present inside the stomach or the intestine. It is not present along the cavity. Okay, it is present only in the viscera. Okay, so whenever there is a perforation of the stomach, or whenever there is a perforation of these areas, it is actually called as the perforation of the hollow viscous, which is actually cause two complications like peritonitis, along with a condition called as pneumoperitoneum. Okay, a pneumoperitoneum can be detected by a sickle-shaped, okay, sickle-shaped hyperlucency, hyperlucency below the ab, right right hemidiaphragm. I think we learned about this before, right? Yeah, right. Okay, sickle-shaped hyperlucency below the right hemidiaphragm is the one that actually suggests that you might be looking at a patient of perforated ulcers. Okay, so you are not actually visualizing the the stomach through barium study, but actually if you are suspecting down, first let us say a patient came down with abdominal pain and you took down an abdominal x-ray, and in the abdominal x-ray you are going to see a sickle-shaped hyperlucency. Sickle-shaped hyperlucency in the sense, generally along the right hemidiaphragm there should be liver and it should be hyperdense, right? And just below the liver you are going to see a blackened area, something like that the gastric bubble has come down onto the right side, something like that. So you will be seeing at two black areas, one under the right hemidiaphragm and other the left hemidiaphragm. So it is actually suggesting you, yes, that you might be looking at a perforated ulcer patient. Did you understand? Yes or no, guys? Remember the complications of duodenal ulcer, and then you also learned that yes, it is going to happen, it is going to cause the rupture of the left gastric artery, and it is also going to cause the left gastroduodenal artery, right? So in such kind of duodenal-pancreatic artery as well, right? So there are, since the celiac plexus is present around this area, what actually happens is that it is going to cause hemorrhage. Okay, it is going to cause hemorrhage. And if you can remember, last time I was talking about a case that has developed down a left gastric artery aneurysm. That patient actually came down to the hospital with abdominal pain. And on barium studies and other things, you actually did not find any kind of an ulcer or a gastric cancer. But so the reason for that gastric aneurysm is related down to acute pancreatitis. But generally, if it is happening down as the obstruction, perforation, or the penetration or into the pancreas, it might be happening just because of duodenal ulcer. So remember that way, not every time. So now you have to understand one thing: the duodenal ulcer, perforations, and the penetration of the duodenum into the pancreas is also one of the reason that is going to cause pancreatitis. Alcohol is one of the reasons that causes pancreatitis, or over irritation of the duodenum also is going to cause the pancreatitis. So it can be vice versa as well. Okay, pancreatitis causes irritation of the duodenum and left gastric artery, and left gastric artery irritation and also of the duodenum is actually going to activate pancreas enzymes as well. Did you understand the relation? So this relation is a complex thing which will actually present down as an event, right? Yes, yes, no, did you understand this logic, what I have been just telling, right? Activation of the gastric contents also could eventually cause, in case of a duodenal ulcer, it could eventually cause you acute pancreatitis as well. Yes, no, guys, right? Okay, and then eventually causing hemorrhage. You have to understand one thing: if the question might be asked, okay, if there is a gastric ulcer and the patient is complaining of melena, so what is the artery that is ruptured? So the answer will be left gastric artery, because the lesser curvature of the stomach is supplied by the left gastric artery. But let us say if you see at the ulcer on the greater curvature, it doesn't necessarily mean to say that it doesn't happen on the greater curvature. Okay, it happens mostly on the lesser curvature, but if you see there is an ulcer that is present down on the greater curvature, now you tell me what are the arteries that are being affected. Anyone? If it is present along the greater curvature, what are the arteries that are being affected? Yes, remember, it is not gastric artery. Is there that something that is called as gastric artery? You can actually call them as small gastric arteries, okay? Small gastric arteries, or you can also call them as gastric epiploic arteries, right? Small gastric arteries, okay, and epiploic arteries, right? But let us say, uh, but right gastric artery is actually, it is happening on the left side. It's sorry, it is happening on the lower curvature of the stomach, right? But it is not it is not happening on the right curvature. It is actually happening in the lesser curvature itself. The superior part is supplied by the left gastric artery, whereas the inferior part is supplied by the right gastric artery, right? Yes or no? If you have remembered the celiac axis, so the questions can be asked for you to recognize along what are the arteries you might be looking at, one in radiology, and the other things that you can be asked down as a clinical questions. Okay, if the ulcer is seen in this location, yes, what is the artery that is involved? Okay, so that's the reason it is important. And remember, this question might be asked, okay, what are the complications of a duodenal ulcer? Okay, perforated duodenal ulcer is actually going to cause, upper abdominal scan with IV contrast agent actually shows extraluminal oral contrast, okay, escape into the peritoneal cavity. You compare it onto the left side here, sorry, you compare it onto the right side here, you can see in the left side there is a hyperlucency that is present along the peritoneal wall, abdominal wall. So there is an increased density along here, which actually suggests that there is an escape of the intravenous content into the abdominal wall, okay, which is actually called as extraluminal oral contrast from the duodenum and escape down into the peritoneal cavity, okay. So this one is the oral contrast release, and this is actually releasing down to here, and this is actually the one that is actually causing the complete uh, intravenous contrast that is showing up as the hyperdensity. So by this, you can actually try to understand that you might be looking at a case of perforated duodenal ulcer. Okay, obstructions, perforation, hemorrhage are the most common complications of an ulcer disease. And here in this patient, you have to repair it by surgery. Okay, the surgery is either by most of the times, just ligation, okay, suturing, as simple suture. Hello. So can everybody hear me? Yes. Okay. Let's try to understand one simple thing. Actually, I've been just looking at a case, but I think I will just try to share it with you guys, actually, that you can understand here. Well, let me give you a history first so that you can just see it's a real clinical practice case, so that you can try to analyze. It's not related down to, abdominal system, but it is related down to chest. Okay, so a 36-year-old female, okay, presents up to the outpatient clinic with a history of epileptic seizures. for the last 3 years. And she has been having 4 episodes of seizures for the last 5 days. Okay. And the common medication, upon giving out the common medication like valproate, sodium, and phenytoin, actually, you know, uh, stops the seizure episode for some point of time, but later on again the seizures comes over. So and generally, yes, there has been no other specifics. Okay, the brain CT on the brain MRI actually, you know, showed no abnormality that is related down to the cerebrovascular deficit or any kind of brain lesions. EEG appears to be quite normal. Okay, and then the patient also complains of respiratory distress. So that's the reason a chest X-ray has been taken. Now you have to try to analyze this condition and tell me what could explain all the things that the patient presenting up with seizures and also respiratory distress, right, chest pains and all other things. Okay, right now you have to explain all of them just based on this X-ray. It's a very interesting case. I guess most of the times, most of you people will not be able to diagnose this condition because I tell you beforehand itself that's a quite normal X-ray. There is nothing abnormality in it. Okay, but you have to tell me what could be the clinical condition that might be related behind this. Did you understand the case? A 36-year-old female presents up to the OP clinic with a history of seizures for the last 5 days, where the empirical management with the drugs like phenytoin, okay, and valproate did not control seizures. And during the hospital stay, she also had 2 episodes of seizures, okay, suddenly. And then she has been complaining of respiratory distress, so that's the reason why chest X-ray has been taken out. So is there any kind of a clinical condition that actually explains the seizures and respiratory distress and all the things in case of a normal CT and in case of a normal chest X-ray? Normal head CT with no brain lesions, no brain cancers or brain abscess or any other condition or related down to epilepsy. EEG shows to be normal. Electroencephalogram seems to be normal. Okay, so what could be the clinical condition that might be associated with it? Well, actually, somebody was saying encephalopathy. Encephalopathy generally should have any kind of a brain edema. Okay, but brain edema did not show up, or also there is no condition that is related down to portal venous hypertension, congestive heart failures as well. The BP seems to be quite normal in this person. Okay, so you can technically say it as encephalopathy. I guess yes. I mean, say I'm certainly sure that most of you people cannot tell the diagnosis of this patient. Okay, you can't call it normal, but there is a peculiar diagnosis to this condition. Asking a single question in history is going to unreveal everything which is related down to this case. So just give it a try. Yeah, there is nothing serious in this one, but still, you have to think out of the box while you actually make out. Don't look into that X-ray, okay, because that X-ray is quite normal. Nothing abnormality is present in that one. But after I came to look at both the head CT, chest X-ray, and along the vitals and along the case sheets, once I looked at it, I just asked one question, and that explained me everything. And I mean, completely, I was able to diagnose the case and treat better. Well, okay, the diagnosis is nothing. The diagnosis is a simple sexual abuse. nothing else. Anxiety disorder, okay, which causes most commonly epileptic seizures in young females. A sexually and a physically abused females having frequent epileptic seizures is the most common cause. 90% of the cause of seizures that is caused in young females with no history of epilepsy or any kind of brain lesions or viral or bacterial infections. Okay, the most common kind of reason for seizures in young females is physical and sexual abuse. Of course, I told you it is not related down to the respiratory system. The only indication we had down to take down a chest x-ray is that because she's having respiratory distress, right? So that's the reason we took down a chest x-ray and came to find out. So when we are looking at the chest x-ray, actually I came to ask it a simple doubt, because on the chest x-ray I was able to find along the left lateral end of the clavicle that there is some kind of inflammatory region along that. And I asked her a simple question: have you and have your husband have been fighting very severely these days? The answer was yes. And the patient is complaining that yes, they were frequently getting into the fights and she has been physically abused. So that's it. It explains the condition. 90% of the seizures, along with respiratory depression and inflammatory changes along the bones, is the one that actually completely solves the case. So with a simple x-ray, we were able to completely diagnose a condition that is related down to physical abuse. Yes, interesting, I guess, right? The case is interesting because the recent researches actually shows that yes, most of the seizures actually are, caused by home abuse. See, sexual and physical abuse in adults is the one that are actually causing psychogenic non-epileptic seizures in adults, which is quite common, right? See, seizures in presence of doctors. Yes, she has a seizure that is present inside the hospital. Recurrent status? Yes, recently she had 3 episodes. Multiple unexplained physical symptoms, including the diagnosis of fibromyalgia, chronic pain. That is there, right? And multiple operations or invasive tests. Yes, she has been taking up a encephalogram, MRI, CT, blood tests, everything. Yes, that is there. Psychiatric treatment? No, she did not gone to psychiatric till these days. But yes, she has been having these psychiatric depressive episodes recently. And then, yes, she has a particular history of sexual abuse and physical abuse, which came to be revealed by the inflammatory changes along the lateral end of the clavicle, right? So, which explains everything. And you can take this patient that is related down to depression, which is related down to a breaking marriage. So, a psychiatric condition will eventually cause you seizures. Interesting case, I guess, right? Because you might be thinking about bigger diseases like encephalopathies, brain tumors, epilepsies, and abscesses, respiratory distress, congestive heart failure, or a lot. Sometimes, it is a very simple reason. Actually, I remember about this thing because when I was in the university, actually, there has a student who had a stress that is related down to the examination, and she had a seizure. And she must be thinking that the she has been having seizures frequently. So, which I came to understand that this might be happening because of the stress that is related down to examinations, which actually is called as HET phobia. Okay, talking to teachers, fear of examinations, answering questions, right? Frequent copying, frequent delays in the works, and then finally doing it very, very fast with incompleteness, non-concentration, all other things, which is related down to the examinations and anxiety that is developing down the examinations or being tested is actually called as HET phobia. I guess most of us have that problem. Yes or no? You are afraid to talk to the teacher. You are afraid to, do your homeworks. Yeah. And you are going to find out that the shortcut ways. And then finally, you are getting defensive against the teacher. And that kind of a psychiatric problem is actually called as HET phobia. So I guess 90% of our medical students think that the teachers are the torturing human beings, much more bad than the second Civil War soldiers or whoever. Okay, we seem to be the real psychopaths here. Okay, so I guess people don't be afraid. I'm not a villain. Okay, all right. So let's continue. Let's just I get just a little bit carried away because of the conditions. All right. Okay, but right now we are going to learn about a very, very important chapter. Okay, pay a lot of attention to this chapter because you can expect an essay question from this chapter. All right, listen very carefully. This chapter to continue in the fluoroscopy as well. Okay, first let us complete this one, and then we get into the fluoroscopy of the same region. Okay, right. Listen carefully. This chapter is very important because you can expect an essay question from here. All right. Okay. We are going to learn about the bowel obstruction and ileus in this session. And the reason why I actually skipped this part before, but right now put it here, because that we are trying to learn about the pathologies of different organs in the region wise. Okay, we are going to look at the upper gastric upper gastric tract, then stomach and duodenum, and then we are going to learn about the intestines as together, right? So right now we will complete the intestinal normal abdominal X-ray, and then we will go down to the pathology of the abdomen, and then we will go down to the fluoroscopy to learning about the peculiar diseases. This chapter is very important and a little bit difficult to understand, but the radiographic features are quite simple. You will be learning only something around like 4 or 5 to radiographic features. That's it. Right now, you have accumulated yourselves with a lot of clinical conditions. We have esophagitis, esophageal carcinoma, gastritis, duodenitis, duodenal ulcers, diverticulosis, and then we have pancreatitis, we have cholecystitis. So right now, we have completed all of the major inflammatory conditions, which is directly related down to the bowel obstructions and ileus. Remember, the most important reason for bowel obstructions are ileus, okay, which we actually call it as paralytic ileus. Last time I told you the reason also why, which is actually going to increase the secretions of VIP and also nitrous oxide, which is actually causing the complete gastric motility to go vague. So if it is lost, we call the condition as paralytic ileus, right? And right now, what actually happens here is that we are going to learn about the normal abnormal patterns of the intestines to see how exactly a bowel obstruction looks like. Okay, so and we have to be aware of their etiological conditions as well, their causes as well, and then you have to see that these bowel gas patterns will also appear the same, either you have done it on a conventional abdominal radiograph or by CT scanning. So the thing you have to try to grasp here is that the radiographic features must be evident on two investigations, one on conventional radiology and other on CT scanning. Both of them will be sharing down the equal radiographic features. And then, but still you have to understand, like I have always been saying from before, yes, CT and MRI seems to be the most sensitive investigations of choice when it is coming down to the examination of abdominal contents, abdominal viscera. Okay, so it is superior, CT is superior in revealing the location. Yes, whenever there is an obstruction, you are able to locate it exactly, and then you are going to look, estimate the degree of it, and then also find out the etiological factor of an obstruction just by observing, the clinical, just by observing the characteristic features of the radiography. All right. And then they also sometimes demonstrate any signs of reduced bowel viability. Reduced bowel viability in the sense is that you are going to see the peristaltic movements or the normal physiological functions may have been affected, and they will be actually showing up some kind of radiographic signs as well. Right. First, you have to, whenever you get an abdominal x-ray before yourselves, you need to ask three questions which are very, very important. Okay, the first question is that is air present inside the rectum or the sigmoid? Okay, let's try to understand each part of these questions and try to answer them back. Okay, let's say, okay, air is present in the rectum or the sigmoid. Okay, is it normal, abnormal? Tell yes or no, right? Air should be present down in the sigmoid, colon, and the rectum. Yes, no, normal. Okay. If the air is not present there, something is wrong, right? Okay. First question we get came normal. Okay. Are there dilated loops in the small bowel? Okay. The small bowel should not be extending beyond 2.5 centimeters, but they are abnormally dilated along some of the regions. Okay. So is it normal or abnormal? Some of the regions came down. Okay. There is air present down in the sigmoid rectum. Sigmoid colon and the rectum. Okay, that is tend to be normal, but still, you on the second question, where you are trying to ask the second question, okay, if there are any dilated loops along the small bowel, the answer I say that okay, yes, there are dilated bowel loop shadows along the left side of the abdomen. Okay, so is it normal, abnormal? Abnormal. Okay, perfect. Then we come down to the third question. Are there dilated loops of the large bowel? Okay, the large bowel loops are present down in the lumbar regions, and yes, there are no abnormal dilatations along the large bowel. So finally, is it normal or abnormal? It's normal or abnormal. Normal. Okay, so now for two questions among this, we came down to have an answer called as normal. The only abnormality we have here is that is related down to the small bowel. So based on these three questions, can you tell me or suspect me what kind of a clinical scenario that I might be looking at? Okay, abnormal dilatation of the small bowel loops. Abnormal dilatation of the small bowel loops. Can others hear me? Okay, Shubham, I think maybe you need to exit and come over. Okay, fine. Now tell me, so you have got abnormality for three question, abnormality for one set of question, and then you have other two questions to be normal. So what is the clinical scenario that you might be suspecting? Answer it. What are you suspecting? Or at least you tell me which region are you suspecting, which part of the intestine are you suspecting that it may be having a pathology. Nashra goes up with jejunum. Okay, other people? Ileum, ileum, jejunum. Okay, when you are saying ileum, are you talking about the small intestine, or is it something else? Okay, right. See the parts of the complete small intestine. Okay, right. The whole part of the small intestine. Okay, like jejunum, ileum, and other things. The small intestine. All of them are actually involved with it. All right. Okay. But let's try to get into more details and see what exactly and try to understand if that is how we are going to break down this mystery here. First, you have to understand here one thing, that any kind of an abnormal intestinal gas patterns, any kind of answer no or abnormality to those questions had to suggest you that you might be looking down at an abnormal X-ray. And then the abnormal gas patterns generally can be divided down into two main categories. So first you find out if there is an abnormality or a normal X-ray you are looking at. And then you are going to categorize the gas pattern. Once you get the gas pattern, transverse colon part is large. Okay, right. So you are going to look at the abnormal gas patterns, and those gas patterns has to be learned and recognized. So that is what we are going to try to achieve here, that we are trying to learn how these abnormal gas patterns look like. So they can be divided down into two main categories. Okay, which one is the functional ileus? Okay, functional ileus in such kind of a situation where certain part of the intestine, okay, certain part of the intestine is abnormal, which is actually called as a sentinel loop. Okay, only some part of the intestine is actually going down. Okay, only some part of the intestine is actually affected, and such is a localized reaction only to that part. So such thing is actually called as a sentinel loop. So whenever you see only certain part of the intestine is dilated, you call it as a sentinel loop. Fine. And then let us say if you are looking at the all over dilated loops along the abdomen, you are going to call it as generalized adynamic ileus. Okay, generalized adynamic ileus. You can technically localize if it is present down in the small intestine, large intestine, right, or rectum or sigmoid or something like this. You can't actually recognize and try to put it down to localize it down to a certain part of the abdomen. So that's the reason you call it as a generalized adynamic ileus pattern. Okay, so localized ileus, a part of the abdomen or a part of the intestine is completely going abnormally dilated, and that one is actually called as a sentinel loop. And then you are going to look at the whole part of the abdomen looking completely dilated, and you cannot divide itself as the small intestine or large intestine. So, and then you are going to call it as generalized adynamic ileus. Okay, and then so these are the ones that are actually falling under the category of functional ileus, which means to say the ileum and other conditions are all other organs are going to functional well, but only due to owing to certain etiological factor, they are going adynamic. Or certain part of the intestine is also going adynamic. So localized, if it is localized, you call it sentinel loop. If it is whole general abdomen and it became completely paralytic, you call it as generalized adynamic ileus. But there is another condition that might be happening because of a principal reason due to obvious obstruction of the intestine, so which can be categorized down into two conditions, that is called as the small bowel obstruction and the large bowel obstruction. So remember, it is mechanical. Okay, this is, you can also call functional ileus as the non-mechanical obstruction. But if it is a something solid structure or a visible structure that is actually obstructing the lumens of the intestine, you call it as mechanical obstruction. And it can be divided down into two categories, one as the small bowel obstruction and the large bowel obstruction. Okay, is there any difficulty here? I think abnormal intestinal gas patterns are divided down into two main categories. Okay, one is completely functioning, but still some part of the intestine is not working well. So which is called as a localized ileus or a sentinel loop. Then the whole part of the abdomen, you cannot localize this abdominal intestinal gas pattern, and then it is going to happen because of adynamic reasons, and so that is the reason it is called as generalized adynamic ileus. Then you have true obstruction that is related down into the intestinal lumen. Okay, so such kind of thing is called as a mechanical obstruction, which can be subdivided into two types, which is like small bowel obstruction, which means to say obstruction that is present particularly in the small bowel, and then you are going to look at the large bowel obstruction, where the obstruction is present down in the large bowel. So you can clearly demarcate if it is present down in the small bowel, or it is present in the large bowel as well. So that are the abnormal gas patterns. Now let's try to understand the pathophysiological mechanisms of this one, and it is very important to understand these things because that is the one that is going to give you a complete idea about the patterns. Okay, first you have to understand the sentinel loop, functional ileus. Let's try to understand this one. Functional ileus is a category in which it is presumed that one or more loops of the bowel lose their ability to propagate the peristaltic waves of the bowel. As simple as that one. Okay, a certain part of the bowel, okay, every bowel has got valvulae conventis and loops, right? Hostrations, valvulae conventis are there, right? Or ilia coli are there, right? These one, okay, are called as the loops, and only one or two parts of the loops, a smaller area of the loop is technically losing its ability to cause peristaltic movement, and it can be happening down to the condition that is related down to excessive irritation or inflammation. Okay, so which is actually called as a functional type of obstruction, which is also called as non-mechanical obstruction. Okay, there are two types of intestinal obstructions. One is functional obstruction and the other is mechanical obstruction. Okay, it is also called as a functional ileus, where one or more loops of the bowel lose their ability to propagate the peristaltic waves. And the reason behind this is actually happening because of that local irritation or inflammation. Now, let me give you a clinical scenario and you tell me. A, a 48-year-old female has been complaining of right hypochondriac pain with a positive Murphy sign, has been complaining of, okay, right hypochondriac pain along with nausea, vomiting, and a positive Murphy sign. And when taken down, an abdominal X-ray shows up dilated bowel loops along the region of the right hypochondrium or the right upper quadrant. So what is the clinical diagnosis and what could be the reason? It is obviously saying that it is obstruction, right? And a dilated obstruction, okay, a dilated loop along the right hypochondriac region is the one that is actually telling you that there is a functional type of obstruction, which is a functional ileus, right? But what exactly is the clinical condition that is actually causing this kind of functional ileus? So obstruction is a resultant of this problem, but what is the real problem that is causing this one? So that is based upon history. You tell me. So how are you going to proceed with this patient? What are you going to look for? What are you suspecting? What is your provisional diagnosis when I gave you the symptoms like that? Does you have right-sided abdominal pain when it is related down to ulcer, Shafiq? Liver inflammation? Okay. Are you talking about hepatitis? Appendicitis? Okay. Do you think that your appendix is present down in the right hypochondrium? Shubham, Do you think that your appendix is present in the right hypochondrium or right iliac fossa? Is it present in the hypochondriac region or the iliac region? Benedict, Clara, Sandra, Martin, Nashra, Ankita, Reshma. You see, there are a lot of good guys here. Speak up, speak up. Pancreatitis, okay. One of the good reason, because she has a positive Murphy sign. What is SID, Reshma? What is SID? Of course, it has got segment obstruction, that is true. But I'm asking you, it might be happening because of inflammation. Are you calling it as ileitis, or is it happening because of something else? Nashra, cholecystitis. Okay, Rahul thinks it is pancreatitis and Nashra thinks it is cholecystitis. How many of you people agree with them? I don't agree with Hisham and I don't agree with Shubham because it is already ruled out. Okay, how many of us think it could be happening because of pancreatitis or it could be happening because of cholecystitis? So how are you going to prove it? So you are going to proceed up with a CT scan, right? Pancreatitis, you are going to look for pancreatic exudatory inflammation, right? And cholecystitis, you are also going to look for enlarged gallbladder and exudative inflammation around the gallbladder, okay? Increased size of the gallbladder, surrounding fat stranding along the gallbladder is the one that is going to give you the radiographic features of cholecystitis. A positive Murphy sign can be indicating that it is cholecystitis, and it can also be a reason that it might be related down to non-obstructive jaundice, right? Okay, so that's the reason we are going to further investigate this patient and go for an CT scan. Okay, well, Shubham, if you are going to have appendicitis, okay, you are going to look at the bowel loop that is present down in the right iliac fossa that might be, causing as a dilation, okay? If it is related down to the appendicitis, you are going to look at the abnormal bowel dilatation only if that region, okay, which is right iliac fossa, all right? Yes, unless the appendix is present down as completely retrocecal, and then it is present down as the high level appendix. Only in case of high level appendix, yes, you might be looking down at such kind of reason. Okay, but still you have to rule out cholecystitis and pancreatitis in that situation. Is this clear for all other guys? Yes? No? Benedict? Is this clear? Clara, is this clear? Respond, guys. Right? Okay. Now let us try to look at how are we going to look along the, what are the radiographic features. Okay, two kinds. What are those two kinds? Localized ileus, okay, affects only one or two loops. One simple definition: generalized dynamic ileus, where all of the loops of the large and small bowel intestine are actually, and also stomach is also involved with it. So this one is actually called as generalized dynamic ileus, right? Now, let's try to learn what is mechanical obstruction. Mechanical obstruction in the other sense, on the other category, it is actually causing an abnormal bowel gas pattern, that's okay. And then it is causing an obstruction that is a physical and organic and obstructive lesion that is visible to the naked eye. Okay, the functional types, you cannot actually find out the reason unless you are going to look at for the anatomically related structures, okay, because it is a functional type. So that's the reason you are calling it as functional type or physiological type or non-mechanical obstruction. But here in mechanical obstruction, you are going to look at it is physical and it is organic. You can absolutely locate it, and that one is actually going to prevent the passage of the intestinal content and thereby causing the loss of peristaltic movement of that area of the intestine, and they are going to cause either the large bowel or the small bowel blockages. Okay, so such kind of thing is actually called as mechanical obstructions. So there are two kinds: small bowel. If it is happening in the small bowel, you call it as small bowel obstruction, and if it is present down in the large bowel, you call it as large bowel obstruction. Remember, they are called as SBO and LBO. All right, then now while you try to understand this, first you need to understand what exactly are these loss of gut. There are something that is called as the loss of gut. Last time also I explained you the physiological mechanism that is related down to this, but let me recall once again. Do you remember a bowel reacts down to a mechanical obstruction or in more or less predictable ways? So what actually happens is that loops proximal to the obstruction, okay, listen carefully, loops above the obstruction soon become dilated with air and fluid, okay, and this will be an acute reaction, and this can occur within few hours of a complete small bowel obstruction. So let us say if there is obstruction present down in some part of the small bowel, what actually happens is that there will be starting of filling up of air or fluid above this level. So you are going to see the radiographic sign as abnormally dilated bowel loops above the level of obstruction, and you are going to find out a region there will be sudden stoppage of the bowel shadows. So where is the obstruction? The obstruction is present down in the distal part because the dilatation of the proximal part suggests that the air cannot be escaped from the distal obstruction. Is this point clear? Okay, if it's not clear, let me repeat once again. Yes, no. Okay. Reshma, no. All of the guys, no. All of the guys, yes, no. Okay, let me repeat it. Maybe I'll try to explain thing here once again, if you can remember. Let us say this is the intestinal loop. Okay, let us say this is the intestinal loop, like this, something like this. Okay, let us imagine, okay, if you are dividing down into this into two parts, okay, two parts, you can call this one as the proximal part, okay, and this one is the distal part. Or as a whole, this one is the intestine as a whole. Or let us say this, only this small region, okay. So let us say this is the distal part and this is the proximal part. Is it clear until here? Yes, no? Did you understand this? Right? Now, let us imagine in any part of this intestine, let us say there is an obstruction. Let us take it this whole place here itself. Let us say there is an obstruction that is present here. Okay? Okay, this is a physical obstruction, a true obstruction. You can locate it, you can look at it. Okay, and then let us say here this is present here, and what actually is trying to happen is that, so which became the proximal part? This whole thing above became the proximal part, right? So now what actually happens? This one starts to dilate. So this part of the intestine became dilated and it is looking as a dilated loop. You see, it looks like this. So when it became dilated, so what actually happens? You will be looking at the sudden stoppage of the dilatation of the bowel here at this region, okay, which will be looking something like this. The shadow is looking something like this in the stomach. So this is an abdominal X-ray you got, and it is looking like this. So by this, you can clearly understand this black shadow is nothing but your bowel obstruction. Found it? Clear now? Yes, no? And then there's a small air that is present down in the other areas, okay, which is fine. But only a single loop is completely dilated, and it is suggesting clearly that it is happening because of obstruction. Is this clear, guys? Yes, no? Didn't you understand now? Yes, right? No confusion? Okay, this is a quite simple concept. The radiographic features are quite simple, but maybe you're trying to understand the pathophysiological mechanism, it might be difficult. Okay, right? Okay, let's continue with that. So now, actually, that kind of obstructive mechanism is going to cause you something within a few hours. And remember, then the peristaltic will continue except in the loops of the one that are involved in a functional ileus. Okay, the peristaltis will keeping continue on in an attempt to propel the intestinal contents to the bowel. Okay, then you see here, if there is a sentinel loop, what actually happens is that all other parts of the intestine will try to give up the peristaltic movement. Only that smaller part where that the obstruction might be present or that the local irritation is the present, only that part will not be having peristaltic movements, but all other parts is going to have peristaltic movements. So which means to say that peristaltic movements healthily happening in all other parts of the intestine are going to accumulate fluid and air. Yes or no? Okay. See, remember, let me come back again to this picture. Okay. Let us say there is a small obstruction that is present down along this region, or let us say there is an inflammation that is present along this region. So what actually happens is that the all intestines, all the loops above is actually going to cause the peristaltic movement and collect air and fluid in it. Okay. And this one, all the next loop is also going to cause the peristaltic movement and is going to collect the air and fluid in it. Right? And then below down that one also, it is going to collect air and fluid in it. Okay, only this region is going to show up as an abnormality. Okay, there is nothing else that is present down here, and you see here there are bowel loops here all around that region. Okay, this one will look completely white because it is not moving. Okay, this one will look completely white because it is not moving, and then I'm going to look at like this. Okay, all other bowel loops which are completely normal, undergoing normal peristalsis, will eventually form up a region like this. So your diagnosis that is related down to the intestinal obstruction is given out by observing a multiple air fluid levels in the abdomen. Simple. Your x-ray will look something like this. Okay, a hyperdense area in the down causing fluid level, and then hypodense area or a radiolucent area above is the one that is telling you that you are looking at a bowel loop. Okay, fluid, and this is air. So multiple air fluid levels in different steps. So let us make out the continuation of the intestine right now. You see here the intestine is coming out like this. The loop is actually going out like this. Can you look it? Appreciate it? You see here, this is the thing like this. Okay, so this is how it is. Did you understand? Where am I looking at? So the obstruction is present this area. Got it? Is this point clear for you guys? Yes, no? Right? So you are looking at an intestine, something just like this, the way how I drew it. Okay, this is concept is quite simple. Okay, the recognition is also very simple, but the physiological mechanism, yes, it is difficult for you to diagnose. Okay, see, the bowel loop obviously has to look something like this. because it is present down like this, okay, all the gravitation dependent areas and where the peristaltic movements that are happening is the one that is actually going to cause such kind of multiple air fluid levels. So now you understand one thing. So this is the region of the inflammation, or this is the region of interest, obstruction, right? So such kind of place is actually called as the anatomical. Remember, it is actually called as the anatomical lead point. Okay, this is actually called as the anatomical lead point. Okay, it is not lead, plum bum, PB. No, it is not lead. Okay, lead is a metal. This is actually the anatomical lead point. Okay, leader. Okay, this is an anatomical lead point. So the region of interest that you are looking, where the obstruction has been present, is actually called as the anatomical lead point. So any kind of abnormality in the peristalsis of a certain point of the intestine is actually called as the anatomical lead point disability. Okay, anatomical lead point disability, or the disability, is the one that will actually cause multiple peristaltic movements that are continuous in other parts of the healthy parts of the intestine, and that one is actually going to propel, it is trying to propel the intestinal contents except for that region. Okay, and then loops distal to an obstruction will eventually become decompressed or airless as the contents are evacuated. Now let us say the things that are present below will eventually go on because there is an external opening and there will be releasing out towards the rectum. But what about the things that are present above that obstruction? They won't be eventually moving down, right? So that's the reason loops distal to an obstruction will eventually become decompressed over time. They become airless. So which means to say below the abdominal level, okay, below the intestinal obstruction level, over time, when you make an intestinal, abdominal X-ray over time, what you will be looking at in another X-ray is that you will be looking at multiple air fluid levels here, here, okay, and then here, and then here. But you are not, okay, then you are going to look at a solid structure here, but eventually smaller air packets are coming down here. So you see here, by this I came to understand these are the small air packets. Okay, small air packets are completely negligible. Okay, small air packets are completely negligible things. Okay, just sometimes you don't even see that one. So the absence of air present down in the sigmoid or rectum. Okay, so absence of air in the sigmoid of the rectum. So which means to say the air has been or not. Okay, but here the air is seen. So which means to say air is present. We answered to that first question as S. Okay, is there air that is present down in the small intestine? We answered no, because we are seeing at multiple air fluid levels. And then is there, what is the third question we asked about? We asked about if, okay, if there are dilated large bowels, then we say that, okay, there are no large bowel dilatation, because in the lower part we are seeing that there is only small air packets, so this is not large bowel. So to S, no, and S. So by this I localized myself, yes, it is present down in the small intestine itself. So obviously my picture is looking down at small intestine itself, right? Even either I understand the concept, or either I answer yes, no to these questions also, yes, I will be able to make down the particular diagnosis. Is this concept clear, guys? Yes? Okay. Now, so they became decompressed distal to the obstruction. Yes, you have to understand they become decompressed, okay, which might be looking down as small air packets, or become completely airless, okay, which become completely hyperdense. And then the same thing that is related down in atelectasis also, where when it is the lung is completely collapsed or compressed, it looks as hyperdensity. When the intestine is compressed or completely, it will be brought together and it will be looking hyperdense. Okay, but above it, you will be looking at multiple air fluid levels. Okay, in mechanical obstruction, the loops that will become most dilated will be either the loop that is with the largest resting diameter before the onset of obstruction, or the loops of the bowel just proximal to the obstruction. Remember, in case of mechanical obstruction, the dilatation should be much more abnormal. Let me visualize how it is happening. Okay, let us say if there is a mechanical obstruction that is present down here. Okay, that actually I was talking about a sentinel loop before. Okay, now let us take again the same intestine as well. Okay, now there is a complete obstruction here, a complete obstruction. Now what actually it has to look down is that anything that is present about to this level, okay, let us say the largest resting diameter before the onset of obstruction, okay, just before the onset of obstruction, okay, let us say this is the resting loop here. Now this one will become completely abnormal. Okay, let me draw up the fluid levels so that you can actually understand. This whole one, okay, let us say this one became a complete dilated. This is the resting one. So this one became air fluid level. This one here, it has got an air fluid level here. Then the above it, okay, this one is going to cause a little bit of much more bigger dilatation. So it is going to cause an air fluid level somewhere around here. And then it is going to cause this one because the air has been entering more from above. So this one is, because this is close to the mouth, this part is close to the mouth. So this one will be showing more air in it and little fluid in it. Okay, little fluid in it and more air in it. Okay, and then this one also becomes more air in it. Okay, with a little more fluid in it than when compared to the proximal region. Okay, and then here this one became abnormally dilated. So now you see here this size of dilatations, you are going to look at these loops or something like this, okay, as abnormally dilated things and dilated things like this, abnormally dilated things. So that is what you are going to look at, a large bowel dilatation. So if dilatation is greater than 2.5 centimeters, you are going to look at it as mechanical obstruction. Simple. Is this concept clear for you guys? Okay, it's the same mechanism that is happening due to a solid obstruction. But what exactly I'm trying to say is that, okay, a functional ileus is actually at an active peristalsis, but this one is a mechanical obstruction. Just about the level, you are going to see bigger air fluid levels, and your X-ray is going to look like this. Something simple bowel obstructions. Got it? Understand? Clear? Yes, no? So that is how you are going to first differentiate it between a mechanical type of obstruction or a non-mechanical type of obstruction. Is everything clear here, guys? Right? So did you understand the concept? Okay. 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 Remember, obviously, yes, myocardial infarction people, cerebral stroke people, all of them are acute emergencies as well. But this person will completely die off in very fast thing. But I tell you, most of the myocardial infarction patients could have already developed collateral circulations. Okay, in the first stroke, after the first stroke, most of the cardiovascular system is actually going to develop collateral circulation, and that the same thing is also happening down in the brain as well, because you are going to trigger a mechanism called as neovascularization. Okay, which is activated by the inflammatory mediators. Okay, chemical mediators actually starts, you know, these cytokines are troponins and cytokines are going to increase, right? So they are right, that's true, right? And they are going to cause neovascularization, and collateral circulations are eventually developed over time. So if the person did not eventually die of a mild stroke for the first time, the person is highly unlikely to die if you intervene with the patient with oral medications. If you treated the patient correctly at that point of time, if your diagnosis is correct at that point of time, if you were able to diagnose him clinically and give him medication immediately, you are highly going to cause the person to live almost for the next safely for the next coming few months. But when you are not trying to intervene with the patient with an intestinal obstruction, you are obviously going to lose the patient within 24 hours. So you have to immediately start either decompression of the abdomen by either intestinal laparotomic surgery and intervene with it, or either you are going to start up with decompression medications. I mean to say intervention, inpatient decompression management has to be done. Okay, but because these patients will not develop neovascularization, because already mesenteric plexus is an anastomosis, a well-designed anastomosis. Okay, it will take a lot of time. Except for heart and brain, most of the structures will not be eventually developing neovascularization. Collateral circulation will not be developed that fast. I guess that's it. So any doubts, any questions for today's class? Right? And I'm going to, tell you a few little things. Uh, People who have been receiving messages from me related down to the assignments. You see, you can, when you are trying to reply me for my questions, you have to understand one thing, that I have been doing, a good justification down to your answers. But if your papers are rejected or if your papers are declined from checking, it could have been happening just because I have a solid proof that you people have copied it from others. Okay, so who all the people who I find from whom you have copied, be it a scholarship student, rank one student, or blank, or a below average student, doesn't matter who. Even if it is a rank one student, if I found out that you have helped somebody to write the answer, and I am going to compare the first rank 50 students to the other 100 students, and I'm going to compare the answers written by the next 100 students compared to the answers of first rank 50 students. So if I even find a single word which is related down to the mistakes of that students, which obviously happened, I am going to decline those assignments. So when I am sending you personal messages, either you come honest, you come clean and tell me the truth so that I can take a technical consideration of your paper and read. But if you are still theory that you did not copy, sir, I used only Google, I only copy pasted, no sir, I did all by myself, that's not the truth. You are lying to me, and I don't spare lies. I am going to decline the paper even of that ranked student, and I'm going to completely reject all that assignments. So you not only destroyed yourself, but you also destroyed the chance of other people getting good marks. Is this point clear? I think I have already sent messages to so many people down in class 3. Okay, I got some messages from some people, but some people did not even respond to me till date. Okay, so be careful. If I know some ranking students as well has passed down the answers. and I can see exact word count, exact spelling mistakes, right? Exact punctuation marks, exact grammar. It is impossible for no two people will have writing style as too common unless you are copying from the same Google source, unless you are copying from the same person and you have distributed your answers like, chocolates. So I am going to decline those papers completely, and you will be getting personal messages, and they either you come honest and talk to me. If you are not being honest, take in a situation that yes, you have accepted your truth yourself, and you will be not evaluated further on. Is this my point clear? Yes, no? Either you prove me that you did not copy, or either you be honest and tell me whom you have copied from. That's the only way. Yes? Am I clear? Where is Abhijit Tripathi? I have only completed checking down class 3, and I guess I have talked almost to something around like 15 students in class 3 whose assignments has been rejected, and still there are something around like 10 papers I did not check. Okay, still people will be there. Class 1, class 2, class 3, class 4, all those people, let us say, if you have 15 students, which means to say half, almost 60 to 60 students of your class will be rejected, let's say, which means to say 50% of you students are not even working, which means to say these 50 students are going to destroy the chances of all other people. All the classes will be at risk. I know where you are copying from. Either you come clean and tell me before I reject your paper. But when I'm messaging you, if I don't find a logical explanation from you, obviously all the people who are similar down to your answers, I don't care if you have written even from my slides, because I'm not looking at those questions which you have written from my slides. I'm looking at those questions that you have written from the Google, and I'm looking at those mistakes, punctuation marks, symbols, okay, spelling mistakes. That is what I'm looking at. I'm obviously finding it, and I'm obviously comparing it from all the people. So you are not only destroying you, but you are destroying all that group who have copied that answers. And if I find that students have done this one, all the people will be rejected. Okay, but I have sent some personal messages to students who have performed well. Yes, until now the students I have looked in class 3, yes, it is something around like 50-50. Half percent of the students performed well, half the students performed completely copied, right? So I wanted to find out, only I'm looking for that one source. But if I find that one source from the good student who has written, yes, obviously that person is going to come out, and I am going to decline all other papers as well. I will find out, don't worry. If you are interested about your personal evaluations, you can actually message me and we can talk about your own paper and about your personal complete things, okay? If you are interested in learning out why exactly how you can improve your writing style or something like that, if you can actually talk to me personally that way, so that I can help you and evaluate your paper before you itself. Okay, I have done it with something around like 5 or 6 students until today. Okay, so Either you can wait for my message, or either you can actually message me and we will try to discuss your own paper. But if I have sent down a message personally and I said that I have rejected your paper, either you have to prove me that you did not copy it, or either you have to explain me your answers so that at least I can consider your paper. If not, your assignment will be rejected down, and I am going to send this notice down to the department so that your students will be remembered. Okay? So I think it should have been already clear for a lot of students right now. And so I think that's it for today. So we'll take a leave. All right. And tomorrow we're going to continue once again. Tomorrow class will be at 10 o'clock. And tomorrow we're going to complete gastrointestinal system. Right. So I think that's it. Have a nice day. Bye-bye.